Welcome back, everybody, to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US. We are your hosts, like always. My name is Dr. Amrit Bilku.
Hi, I'm Dr. Deepan Kaur.
Hi, I'm Dr. Ravinder Randawa.
And I'm Dr. Alex Kuhn.
And today we are doing our second episode of our new series, the New Grad Case Reflection. We want to say thank you so much to everyone who gave us feedback on our first episode of the New Grad Case Reflection. I think it was probably one of our most popular episodes yet, and our most viewed on IGTV too. I mean, we had 700 views on that, which is significantly higher than what we usually get, and just a lot of positive feedback. So I personally want to say thank you again as well to everyone who reached out. We want these reflection episodes to just be an open conversation about how we felt and what we thought through each case that we present, so that everyone is reminded that we're human, we make mistakes, we're nervous, we're anxious all the time, and we're still learning as new grad ODs to be better every day. So today, Rav is going to be sharing a case with us, and we'll kind of just go through it and kind of learn from her and share our thoughts as we go along. So we hope you guys enjoy.
So this case that I'm about to present is a simple yet a complicated case. It's something that we can all relate to at some degree. So I'll be going over my train of thought, where I went wrong, and what I did right, and what I learned the most. So this case is about a 28-year-old Caucasian male. So he came to the clinic with complaining about pain, sensitivity to light. He had blurry vision, and this was all happening in his right eye. And it started about a week ago, and the symptoms just kind of got worse. So just by listening to my chief complain, what are your top differential diagnoses?
Dry eye.
Yeah. Dry eye.
Sensitivity to light, blurry vision.
Uveitis, yeah.
Alex got it.
Yeah, we were
Alex.
joking. We knew it was uveitis. We knew.
I'm still sticking with dry eye. Every time I hear light sensitivity, I'm like, cornea. Yeah.
Yep.
So upon further testing, his vision in the right eye was 20/70 and the left eye was 20/20. He had about grade 3 cells with mild flare, and his pressure was about 10 with eye care. So this was a case of uveitis. So this patient was originally seen by a different doctor. That doctor started him on Maxidex, which is dexamethasone, every 1 hour, atropine once a day, and told the patient to go see your family doctor for a blood workup.
Oh, atropine once a day?
Yeah.
This was 1%.
Oh, wow.
It takes away the pain.
1% atropine.
Yeah.
Okay.
Yeah. So kind of talking about atropine. So like I know in school, we learned to prescribe homatropine. So either 2% or 5% twice a day for uveitis. So my first case ever as a Canadian OD, I prescribed homatropine, and I get a call from the pharmacist.
Yep.
And the pharmacist was like,
No.
hey, just letting you know, this medication isn't available in Canada.
Yeah.
And that was probably my first moment where I felt like, I don't know anything.
Yeah.
My dumb moment.
No, it's
But
really
yeah.
hard. Yeah. I think it's really hard to prescribe steroids, in my opinion, too. And even the steroid antibiotic combos, because all of the names that we commonly memorized for board exams are all American. Something like Keflex, I couldn't find initially on my list of Canadian medications. And I was like second guessing. I'm like, oh, wait, is it even here? Can I do that? Do I have to be generic? Like, what is this? So yeah.
It helps when a family member is a pharmacist. So if I'm never sure, I'll just text my sister and be like, yo, do you sell this? And then she's like, yes or no. So sorry, Rav.
That's so true. Well, actually, my best friend is a pharmacist, Sapta, if you're listening to this, shout out to you. So I always message her, but that time, she never had time to message me back. So I was like, oh, it's homatropine, like this is the first thing that comes to your head.
Who doesn't have homatropine?
I know, right?
Yeah.
But yeah. What do you guys normally prescribe
I haven't.
You
I
guys ever?
honestly have not had to manage any uveitis patient yet.
Yeah.
As of
I
yet.
had to do a follow-up from another doctor in the clinic because he wasn't
Yeah.
there, but he just put this patient on Predforte. So there was no like cyclo or atropine or anything like that they put them on.
So, well, it
I'm still
depends.
stuck on the home atropine part.
Well,
right now.
you're in the States, so.
That Canada doesn't have it, or that you use something
Yes.
different.
Yes. Sorry, keep going.
There's a lot of things we don't have, Alex. I'm
know.
sure you're just like, what is happening over there?
That was me, don't worry, Alex. When they told me there's no hematropine, I'm like,
Yeah.
I don't know how to manage this case.
Yeah.
What to do?
What are the alternatives? Oh no.
Yeah.
Yeah.
So my original case, I ended up giving my patient cyclo, just 1%. So that's a traditional go-to, cyclo, or a lot of people do atropine once a day here.
I'm just
So-
surprised with atropine because it's like a 7-day
Yeah.
you'll be dilated for 7 days, and I don't know how people would be able to
So
function with their daily lives.
apparently, this was a case that was presented by a MD.
Oh, okay.
Apparently, so they do it atropine every day because when you have uveitis, they say the cells don't function normally.
Mm-hmm.
So it actually
Oh, it
uses up the atropine faster.
faster.
Yeah.
So it actually wears off
Oh.
faster in a diseased eye. So uveitic
That makes
eye.
sense because I was
Yeah.
questioning that too. Why would you put an atropine every day if it lasts for like a week or so?
Yeah.
Okay, that makes
Right.
sense.
It's just not as effective, basically, is what.
Yes, it's not
happens.
as effective in a
Gotcha.
normal eye compared
I
to
see.
a
Okay.
diseased eye.
Okay.
So this patient, he came back 2 days after, and this was the first time I was seeing him. So he reports like good improvement in vision. His light sensitivity was much better. He had about grade 2 cells now, no flare. His vision dropped to 2150. His IOP in that
Oh.
eye was 6.
but he
and
said
he
was
had
doing
that-
better.
Yep, he was doing better. Well, I think when he said he was doing better, I think he was talking about
Like
his
the
pain and light
symptoms?
sensitivity.
Okay.
Yeah.
Yeah.
And so he still had that pharmacologically dilated pupil in the right eye. What would you guys do?
So his vision got worse, but everything else was looking better.
Better. Yeah. So his vision before was 20/70, and now
would-
it's 21/50.
I would
I
do
would
an
dilate.
OCT and see
Check
Yeah.
if there's some sort of macular edema.
Mm.
Oh, Rab is just leading us there. She's like, "Don't worry, I'm pushing you guys
Yeah.
along to help."
Yeah. So he was dilated already. So
Mhm.
took a look at the back of the eyes, no cells or inflammation. So that rules out any posterior uveitis. He
Mhm.
had I did do an OCT. He did have normal foliar contour, no
Mhm.
edema at all. He did have trace ERM, but it was not enough to reduce his vision.
by that much.
Mhm.
Yeah.
So I was like, maybe he has some underlying hyperopia. He never had an eye exam with us. So I'm like, maybe he
Oh,
does
gotcha.
have some hyperopia. Now he's on atropine. So that's why. But everything
Mhm.
else looked good.
Did you scope him?
No, I didn't
Oh,
I didn't scope him. Well, that's a good idea. I should have maybe
Yeah.
gotten autos or scoped him just to see if that was it. But no, I didn't do that.
What
So-
did you do, Rab?
Nothing, actually. I didn't do
Oh.
anything because
Well, 'cause-
everything looked okay. So I was like, maybe
Yeah.
like I ruled it down to like maybe it's like hyperopia, or like that's not
Mhm.
corrected. So even though he was already seen by a different doctor and this was the first time he's seeing me, what kind of questions would you guys ask?
Well, like
Yeah.
so you said that the
Spondylitis.
doctor recommended blood work, right? So I
He
guess my
said
question would be, did
he
you
told
get
a-
it done?
So the other doctor told the patient, "Oh, go see your family doctor for a blood work."
Okay. And then so I guess my question would be, did you go and are any results back, or what did you even get your blood work done for? Like what is that? Like can I have that letter that the other
Yeah.
doctor gave you? Like what did they
So
send you?
the
for?
other doctor didn't give any letter. He just said,
Oh,
"Go see your family doctor for a blood workup."
Did he see his family doctor for a workup?
No, he didn't. It was just 2 days ago. He's
Okay.
like, "Nope, I haven't seen my family
Oh.
doctor." So
All right. Well, I would just kick him out and move on to the next one.
Well, I
good job,
guess-
Deepan.
I was gonna say, like, I guess if you're thinking, clearly the other doctor had a hunch, with uveitis, you want to get blood work done for a reason because you
Yeah.
want to rule out autoimmune conditions, any other systemic or health conditions. So I feel like,
Mhm.
first of all, yeah, asking, did you do that blood work? And then if not, asking for those symptoms for like the conditions that you're suspecting. Like Alex is saying, ankylosing spondylitis. So asking, I
Mhm.
guess, for back pain specifically, for autoimmune diseases, asking for fatigue or, changes in their health or behavior. I don't know. Yeah. Stomach issues for like IBS. Is that what
Okay,
you're kind of
yeah.
going into?
Yeah. No,
Yeah.
those are good, like, typical uveitis questions you would ask.
Yeah.
So kind of like same thing that Amory kind of said. So that's the type of questions I asked. I asked,
Mhm.
have you ever had any episodes before? And the patient's like,
Yeah.
yeah, I've actually been having uveitis on and off. So he's like, it alternates between the eyes for the past 2 years. And he has had about 4 to 5 episodes. I was like, oh,
Oh,
wow, like
okay.
that's a lot of episodes. And, I'm like, it must be pretty frustrating that you're having uveitis every couple of months.
Mhm.
And yeah, he's like, I just don't know. So then asked him a bit more about, like, back pain, any systemic conditions. And he's like, yeah, like I do get some back pain, but like he's like, I don't think it's anything concerning. Like, maybe just I'm just getting older. I was like, okay.
But
And
you
then
said
I
he's
was like, oh,
25.
Yeah,
he's
he's
20. Yeah.
9 or
You ain't getting
28.
that old.
I mean, yo, man, sometimes I wake up and I'm like, yo, man,
oh,
I feel like
yeah.
I'm 50.
Yeah. Yeah. No, I mean, I do feel like that some days, but
Yeah.
So then I asked him, like, like you've been having this condition for 2 years. Like, have you ever had any blood workup done? I know the last doctor sent you. He's like, yeah. He's like, I was sent for a blood workup about a year ago by a different doctor, optometrist. And he's like, everything came out normal. I was like, okay, like that makes me happy. Like, at least he got some sort of blood workup
Mhm.
done. There's a step is taken towards trying to figure out this. Would you guys send him again for blood workup?
Yeah, I think
Mhm.
100% because, even if things are negative once, that never means that it's going to be negative
Mhm.
again unless you check. And then I think I don't remember the details, but I think for some autoimmune conditions and especially like arthritis,
Yeah.
sometimes those findings are not in a standard blood workup, right? You have to ask specifically for a lot of these factors to be checked. And then you have to check like more than one factor because if one's negative, the other could be positive. So yeah, you gotta do a lot of workups, a lot of blood
Mhm.
workup.
But sometimes those blood work results come up negative, but they
Mhm.
could be false
False
negatives, right?
negative or
So
false positive too.
yeah,
Yeah.
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 So yeah, I would definitely do a repeat blood work test.
And that was a year ago. So that
Mhm.
condition could have been super mild, whereas now it's all accumulated over the year. His condition could be significant enough that it actually shows up now, maybe on
Mhm.
a blood
Mhm.
Yeah.
test.
In Alberta, we actually have access to Netcare.
Mhm.
So it's where we can
Oh.
actually see a patient's previous blood work and
Oh, that's
a
nice.
list of medications that they're on, even some conditions that they're diagnosed with.
Mhm.
So I actually went on his healthcare and I looked at his old blood workup. So I'm just gonna kind of go over some of the testings that they did. So, they did the generic testing. So they did his CBC, so his complete blood count. So which just kind of gives the patient's general health.
Mhm.
So which was normal. Then they did looked at his ESR, so the erythrocyte sedimentation rate. So remember, this measures how fast your red blood cells separates from the plasma.
Mhm.
So a higher ESR rate is a red flag for inflammation.
Mhm.
CRP, C-reactive protein. This is kind of the same thing, testing for inflammation. They looked at his creatine levels. That's just making sure the kidney's working fine.
Mhm.
They looked at his ANA. That's just testing for some autoimmune conditions like
Mhm.
lupus, inflammatory bowel disease. It had his RF, so
Mhm.
it was negative for rheumatoid arthritis. They did syphilis, TB, both negative.
Wow.
So I'm seeing all this blood work. And there's one test I'm very curious about, but it's not there. Which one is it? So
We're
when you're
drowning,
thinking-
Rav. Save us.
when you're
Just normal
thinking
white blood
about
cells.
anterior uveitis, you're thinking about, as Amber said, autoimmune disorders. What's that one test?
Are you talking about the one for the ankle? I can't even say it. The ankle.
Ankylosing spondylitis. Yeah.
What's the test for that?
I thought it was all of the ones you just said.
HLA
there's one
B27.
particular. HLA-B27.
Yes.
Yes,
No.
Alex, you got it.
You know what the funny thing was is when you said blood test, I was like, yeah, we need to look for the HL. Like in my brain, that's what I was
Yeah.
thinking. But
Yeah.
like,
That's the most common one too. I feel like that's the
Yeah.
first one that always shows up, but it's like
yes.
I never see blood tests for my patients. It's always, and
Yeah.
we don't have net care
We
at
don't
our
see them.
clinic.
Mm-mm.
We haven't
Yeah, we
signed
don't
up for
either.
that. So I'm just
how
like,
long-
go to your family doctor, go get your blood test done, and
Yeah.
let your family I'll correspond with your family doctor and they'll let me know.
Yeah.
But none of them ever
But then
never
I
happened.
think
net care is not
that's-
even a thing here. So
Yeah. Not a thing for me.
But then I think that's where the disconnect is. Like when you're sending your patient to a family doctor, I feel like they need to know what is that you're looking for, right?
Yeah.
And I'm guessing, like we always say, oh, like yeah, go see your family doctor for a blood workup. But like, what is it that they're looking for? Like they did all this testing, and there's one test that should have been done wasn't done,
Done,
right?
yeah.
Like that was the
Yeah.
number
And I didn't even
one-
know that. I thought that testing would have automatically been in there.
Same. I
Yeah.
thought like when the patient was like, yeah, I got my blood work done, everything's good. I was like, oh, like that's good. I'm like, I just want to maybe see maybe something was very close to borderline being abnormal that maybe will stand out to me, but it wasn't there. So yeah, ended up so HLA-B27, this test is associated with a number of autoimmune disorders like ankylosing spondylitis, Reiter syndrome.
Yeah, that's like
Um,
a arthritis or something,
mhm.
right? Yeah. Oh
Mhm.
man, uveitis specialists are gonna destroy
Hate
us
us
on
for-
this. We know what we're
So yeah, like I end up actually writing a letter to his family doctor, saying, hey, I see that you got the blood work done about a year ago. Everything was healthy, but this patient's still having uveitis, and then we never got tested for HLA-B27. So let's do that. I'm like, and also stated in the letter that the patient is having a little bit of back pain.
Mhm.
I'm like, it could be ankylosing spondylitis. He's kind of following all the other categories. He's having recurrent uveitis that's alternating. He's young age. He's Caucasian. So, like maybe let's just get that tested out as well.
Yeah.
With the patient, what I did was I told him, continue the maxi dex every 1 hour for today. And then tomorrow we'll do every 2 hours. And then I'll see you back in about 2 days.
I think you brought up a good point, Rav, before you continue, about how I feel like sometimes we assume that family doctors or other doctors that are not ODs or OMDs, that they know what we're talking about. And I think it's a good reminder with this case that we really have to be specific with requesting blood work. Because again, right, if you just tell a doctor, patient has uveitis, do blood work to make sure nothing's wrong, they're going to read that letter being like, what blood work? Like, what do you mean? And even with this doesn't relate to this case, but especially when you're asking for neuroimaging, I feel like it gets very tricky when you're looking for a lesion or you want to rule out a mass or a tumor. You have to still kind of guide them to let them know your thought process, to be like, I really want, neuroimaging for this patient. Please pay close attention to the optic chiasm or, the optic tract on the left side or something. Because if you don't, I mean, the patient that you're referring to those doctors, they never met the patient yet. So they never went through the case from start to finish like you did. So their thought process might be completely different. And that's a good reminder to just, to be confident and be clear in the referral. Don't just assume that everyone is thinking the same thing as you. Yeah. Or else it's a waste of a referral.
It is like you never got what you wanted, and then the patient went through all this stuff and they thinking, oh yeah, they're all healthy, but there's something that just got overlooked.
Yeah.
So then 2 days later, I saw him again, and his symptoms were stable. And patient actually ended up going and seeing his family doctor. The family doctor did a pelvic examination, and he said the test was not normal. He's like, it was abnormal. So he actually was referred to a rheumatologist for further testing. So I was like,
Yeah.
okay, that's good, getting your referrals out.
Mhm.
In terms of his uveitis, so he had about grade 1 cells now with pigmented cells, no flare, and his vision was better now. So he's 20/80 today. And then at that third visit, I was like, okay, I was like, continue doing the Maxidex every 2 hours for another 2 days, and I'll see you again. And then he's still on atropine at this point.
Mhm.
So his next visit, so this is his fourth visit with us, he did see a different doctor. So his symptoms are stable. His vision got better to 20/40. So much better
Wow.
vision today. Yeah.
Yeah.
But now this doctor saw about grade 2 to 3 cells. So
Mhm.
quite a jump. So last time I saw him with about grade 1 cells. So
Mhm.
now
Sorry, this
he
is a
kind of,
different doctor at your clinic, or he went to a
yeah,
different. Oh, okay,
no,
okay,
it's a
okay.
different doctor at my
Oh,
clinic.
okay, okay.
Mhm.
Okay.
So he saw about grade. This doctor saw about grade 2 to 3 cells, with 2+ flare, and I trust this OD's judgment on cells. Sometimes it varies the way we measure
Yeah,
grade
definitely.
grade 2 from OD to OD.
Yep.
But this OD, she did a residency with ocular disease, and she's worked alongside other OMDs, so she is very experienced. So I really know that she knows her stuff. So I was like, okay. So she started him on Duracell, and she started him 6 times a day and atropine to every other day. So
Wow, 6 times a day on the Duracell. Okay.
Duracell is a very strong, a
Mm,
very potent steroid.
Yeah.
It's
Isn't it the
equivalent
strongest?
to,
It is the
yes,
strongest. Yeah.
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 it's equivalent to pretty much pred acetate 1% every 1 hour.
Yeah.
So 6 times a day. Um, have you ever guys used Duracell before?
Nope.
Nope.
No? Are you scared to use Duracell?
Yeah,
I'm
I've
pretty
never
similar
had
to Amrit, where I just never really had a lot of uveitis patients
Mhm.
Yeah.
outside of graduation. So
Okay.
I always told myself though, if I did end up having a uveitis patient and I would start them on Pred Forte, like 1%. And if they came back for the follow up, not getting better or becoming worse, then I would put them on Duracell. But I've
Yeah.
never
So that would be your
actually,
second option?
yeah, that would be my
Okay.
second option.
Yeah, I've basically all the ones that I've had, they've got knocked out with the pred, so I
Mhm.
haven't had to use it either.
Yeah, so the patient came back 2 days later. Patient saw me, symptoms stable, VA is even more better now. It's 20/30, 1+ cells, no flares, pressures down to 5. So this was another mistake I made. So this is with uveitis, it's tapering your patients off on steroids.
Yeah.
So I thought this patient was doing really well, like, oh, the second time I saw him, his improving. So I'm like, okay, every 2 hours. But the third time he saw the doctor, it flared back up. So this is where uveitis gets very hard to gets very tricky to treat, is even though you're tapering so slow, you just don't know when that's gonna flare up. So
Yeah.
take your time with the tapering. I think I rushed it. Maybe I should have kept him on for once a day a bit longer till maybe it fully cleared up. I
Mhm.
started tapering him when I saw about grade 1 cells. That's a mistake I made. Maybe in the future, if I had the same patient again, I probably would start him on Duracell, just because when you have recurrent uveitis,
Mhm.
it is harder to bring that inflammation down.
Yeah.
They are harder to treat compared to somebody who is first time uveitic patient. Like you put them on them pred acetate 1% every 1 hour, and the next day everything's
Great.
clear.
Yeah.
It's great. It's like day and night difference,
Yeah.
Yeah.
Whereas this patient, it was definitely took time,
Mhm.
and even I kind of learned that, and I was like, okay, you know what, even though Duracell is such a strong steroid, I'm going to take my time. So
Mhm.
Yeah.
I spread it out to tapering once a week.
Mhm. Yeah.
So I was
Yeah.
like, okay, 5 times a day, once a week, 4 times a day, once a week. The patient also ran out of atropine at the follow up visit, and
Mhm.
I was like, okay, I don't see any flare. And I was like, I guess there's no need for atropine. And he's not symptomatic anymore, right?
Mhm.
So kind of reminding ourselves, like, why are we using a cycloplegic, right? It's to prevent posterior sneaking. I'm like, there's no flare. Inflammation is
Mhm.
getting better. I was like, he doesn't need to be dilated all the time. So I was like,
Yeah.
that's fine. I'm like, I think you're okay with no atropine.
Yeah.
Um,
And it's like, I think what you just said there, where you might have like rushed the treatment.
oh,
Even though I haven't, or sorry, rushed like, the tapering where you just kind of
yeah,
felt like, maybe I should have given it a little bit more time. I
yeah,
feel like that all the time, even when I'm adjusting a patient's RX. Sometimes a patient will come in and, if they have accommodative issues and they come in with the glasses and they're like, well, I can't see with these glasses. They're not comfortable.
mhm,
I've caught myself once or twice changing the prescription really fast and just being like, okay, here's the new RX, try this out. But
yeah,
sometimes you really just need to be patient. Try it again for another week or spend another week, using this eye drop, using these glasses, and you'd be surprised at how many patients just recover with time rather than you always feeling like you need to solve the problem that day, right? You need to
yeah,
fix it right away. And oh, things are getting better. Okay, I'm going to go to the next step right away.
yeah,
Yeah, it's
yeah.
so common. I feel like that all the time.
I think you bring a good point, because I think that's why I said, oh, let's do every 2 hours, because I was like, oh,
Mhm.
you're doing better. And I was like, I get it, how annoying it is to put a drop in every 1 hour for like,
Yeah.
he was already on it for 3 days, and being
Yeah.
on it for the fourth day, I was like, like, it's annoying. I totally understand. So I was like, okay,
Mhm.
you're doing better. Like, let's start taping you. And yeah, that's where I went wrong. And,
Do you
and
think that's connecting with us wanting to be liked by our patients too? Remember
yeah,
when
for
we had this,
sure.
right? Because like
Yeah.
now we're empathizing with them and we're
Yes.
trying to be like, I know you're going through a lot taking these eye drops every day. I don't
Yeah.
want you to be upset with me telling you to take them more. So now why don't you just take them less? Take them
Yep.
whatever you want. Take them a little bit less. Like we're just kind of
No,
letting our
it definitely
patients.
is. You put
Yeah.
I
yourself
also
in this patient's shoes.
Yeah.
One of my attendings from ICO told me that with tapering for uveitis, it really depends on the patient. So there's never a strict plan of what you can do, and it all comes with a lot of experience. So I
Mm-hmm.
think for us, like, if we're not seeing a uveitis patient like every day, it kind of becomes hard to be like, oh, what did we learn back
Yeah.
in
Mhm.
school, or the usual protocol of tapering, and it just kind of comes from experience. So I think with this patient, Rav, you should like write down like what your tapering schedule was and try that for the
It,
next patient, and hopefully
but then, yeah, it honestly, you're right. Like, it's also patient dependent too, right? Like,
Mhm.
I've actually had about like 7, 8 uveitis patient, which I follow from beginning to end. I actually see a lot of uveitis.
Yeah.
So each one is so different, right? There's one that's I had to involve OMDs, and we still can't bring her inflammation down. She's on
Mhm.
steroid meds, and it's crazy. And then other patients, like as I said, like you give them predacetate 1%, and the next day it's all cleared, and that's it.
Yeah.
Like easy taper every 3 days, you bring it down, and that's they're
Yeah.
good. But it depends definitely on. I think that's why case history is so important,
Mhm.
to know, even asking the patient, like, what other drops did you use, which one worked for you, were
Mhm.
you dilated before. So just like getting that information too helps you manage the case a bit better.
Yeah.
And then uveitis, it's tricky. It's
Yeah.
especially, we're just talking about anterior uveitis,
I
posterior
know.
uveitis or intermediate uveitis. That's a whole new level.
Yeah.
that's that's a referral, man. You go.
I think the way that you picked up the blood work though was
Yeah.
so rare because I think a lot of us and a lot of people listening probably will never have access to, the blood work results. Even when I refer my patients to get blood workup done by their family doctor, I don't get the results back. The family doctor doesn't even write me back a letter.
Mhm.
And, sometimes I don't even know what happened because I don't get
What
that
happened? Yeah.
communication back. So having that sort of a network where you can look up their results, I think was a huge win for, the Alberta healthcare. For you guys to have that
Oh,
is
for sure.
so
In
good.
Alberta, we can order our own blood tests now for optometrists.
Oh,
We can.
wow.
Yeah.
But you have to be able to read them too. So Rav also could have
Yeah.
just sent out these blood tests.
Send them, Marisa.
Yeah.
Yeah.
I feel like I would still involve the family doctor just because I'm not too confident in it. Like I felt like he had something else. I felt like he needed further referrals. So
Mhm.
I just always like involving the family doctor.
Good job. So
Yeah.
what happened to him
Yeah.
now, Rav? Like, how is he now?
So I saw him about 4 weeks ago. So he had a couple of other appointments in between. It was just monitoring his tapering. Pretty much he was good. His second last visit, he got his test results back, and he was HLA-B27 positive. Yeah.
Wow.
So
Did they
he
diagnose him with anything particular?
So he has a follow up with his rheumatologist in a couple of weeks. They're gonna do more further testings, but it looks like it might be just ankylosing spondylitis, just from kind of his case history and everything he's having. But yeah, the patient was very happy. He was just kind of really fed up with whole keep having uveitis. Like you're seeing like us every couple of days, being on eye drops for every 1 hour.
Yeah.
It's annoying, right? It takes, you can't work really, like, and being
Mhm.
dilated in one eye. So I guess I could imagine his frustration, and he was very happy that somebody took an
Yeah.
extra step, and like he, even though he's not diagnosed yet, but at least something came up. Sometimes the patient just needs to know there's something else, right? Like there's
Yeah.
a reason why they're having this, rather than just being like, oh, like we'll just see you the next time your inflammation flares up again, and
Yeah.
we'll start you on drops again, right?
It's like giving the Band-Aid treatment versus
Bandage-
finding
yeah.
out why is this happening, right? That
Yeah.
happens so often with patients. They'll always come in saying, yeah, I've had this thing for, every couple of months, every couple of years, this happens. And I'll go like, why? They're like, I don't
Yeah.
know, it just happens. And I'm like, yeah, but I don't want to just give you, an antibiotic again
Mhm.
because this happened. Like, why are you getting so many recurrent styes? What are you doing
Yes.
every day? What, I don't want to just give you the treatment for it, but why are you,
Yeah.
why is this
Yeah.
happening? Yeah.
Yeah, that was my case. And I guess my takeaway from this case would be do your own due diligence, get the information, write that letter to the GP, state clearly what exactly are you looking for, be that person that takes the extra step. And
Mm.
I feel like we're not here, us four, to portray how perfect or the best ODs we are.
Mhm.
We still make mistakes, and we know we can't give our 100% to all our patients. I am booked 15 minutes exams. I can't do everything I want for the patient, but I know I saw the patient for follow-ups, and I know I had time. Like, okay, let me just see, right? Let me
Mhm.
take that extra step. And I think that's what we want all our listeners to do. Take that extra step. That's how we're going to grow our profession and help our patients. Second takeaway is just, with uveitis, never be scared to hit them hard. So if you feel
Yeah.
like you have a tough uveitic patient, start with Dorzol, and it's okay. Just get it all cleared up, then taper. Don't taper and then it flares up again, then you're starting all over again. So
Mhm.
yeah, that's my two takeaways.
I was gonna say, I think your case was a really good example of what we learn in school versus what actually happens in real life. Like,
Yeah.
I don't know about you guys, like when we learned about uveitis, these kind of concepts were hammered home to us. Like,
Mhm.
blood work, look for these results over and over and over and over again. But when you're in the real world, it's kind of different, right? Like, you're not always seeing those blood tests or what tests are being done, and you just assume everything is happening, and you're like, I don't know, like, what's the problem here? So just another reminder, when things may seem simple, they're actually not. Like, you really have to go bend over backwards to figure out things, especially seeing those red flags. And Rav. I'm glad you did
Yeah.
that.
Yeah. So that's why I said it's a simple yet complicated case because
Yeah.
simple because he was doing good, but then it's
Complicated because
right?
it's missing that information.
Yeah.
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 Just a lot of pieces to the puzzle missing.
Yeah.
I'd say one other big takeaway that we mentioned
Mhm.
was be patient because I still have to
Yes.
remind myself of that all the time. Like I said, sometimes if a treatment plan is not working right away or is working, but it's the response isn't as good as you hoped it to be, don't change your treatment plan right away. You know, as new grads, I think we're really eager for we're that generation that wants fast results and we don't want to put in the hard work or we don't want to wait for it and be patient for it to happen. And I feel like I take that out on my patients. Yeah, good job, Rav. We're proud of you.
Yeah.
Yay.
For anyone listening to us talk about this case, please feel free to share your thoughts about it on our Instagram when we post our IGTV or any post associated with it, or comment on the podcasting apps and let us know if you have any extra thoughts, what you agreed with Rav, what else we could have learned from it, because that's what we're here for, always learning.
Thanks everyone for listening to Four Eyes. Make sure to subscribe and check us out on Instagram at Four Eyes Optom for more eye related content. Look out for new episodes every Wednesday. Until then, stay tuned.